Hello, it's Bill, the knee pain guru, and welcome to the Ask Dr. Beck show. Today is Thursday, August 26th. We do these every Wednesday morning at 7:30.
It's Wednesday somewhere.
Yeah, it's Wednesday somewhere. It's been a rough week, so
Yeah.
we're gonna give ourselves a pass on that one. Actually, the past couple weeks has been pretty intense.
It's been rough.
But okay, we are live on YouTube and Facebook right now. How you been this week, Charlie?
Well, and other than it being a rough week, I mean, I'm doing okay, I think.
Okay.
Yeah.
Cool. We were gonna talk about feet this week. Did anything happen with that, or rough weeks sometimes postpone?
Rough week. I forgot my models, but I did put together a presentation, so we can look at some slides anyway, and we can get started on it. Yeah.
Cool.
I wanted to know if there were questions first from the listeners. Yeah.
There are.
Perfect. Let's start with those.
Okay, we had Kathy. Kathy asks, what does it mean in osteopathic medicine if you have a bunion on the same side as your chronic knee pain? Thanks.
Wow. Okay, so first, that's a question with perhaps multiple answers.
Okay.
And let's. Are there more questions?
One.
Okay, let's table that question and come back to it in the presentation because I can answer it better there.
Two more questions. Sorry.
Okay.
Let's see. This one was written in by Sherry. Sherry says, hi, Dr. Beck. Saw you on the Knee Guru in June. Since then, I got Prolozone injection in both bone-on-bone knees, and it went well.
Okay.
The second injection, she added an anti-inflammatory to the Prolozone. The anti-inflammatory was a natural called Truheal.
Tramiel. Got it.
My right leg did great. The left knee swelled up and put me in terrible pain for a week. It's been 3 weeks. I feel much better, but my leg is still tight and painful around the joint and very swollen. It, of course, is very confusing for mainstream medical, but they're trying to get me through it. Nothing is changing the swelling. She put a question mark.
Got it. Okay.
I'm a teacher and already have missed 2 weeks. Any insight on my dilemma would be greatly appreciated. I was so impressed with you on the Knee Gurus show.
Okay. Well, first, thank you. But let's get directly to the question. So this is what I have noticed in clinical experience. Things are different than what they teach in class. Mm-hmm. So in class, they seem to give out a perfect model. You do the injections and patients get better, and there are no other options. Mm-hmm. What seems to happen, though, and this is the way my brain has sorted it out, when I put an injection in a knee, it is fluid that takes up space. That fluid gets absorbed after a while, let's say half an hour to an hour, but that fluid initially takes up space. The space that it takes up moves the knee. It separates the top and the bottom bones, the fibula and tibia from the femur. Okay. So the knee goes from being, let me just make sure that the camera sees this. The knee goes from being this space with a little fluid to being that space. Okay. Because the fluid simply pushes the knee apart. And when that happens, the tissues within the knee can shift their orientation to their neighbors. Okay, so you're one way, the knee is in one physical manifestation before the injection. The injection causes a different physical manifestation. And then the fluid goes away and the knee settles into a different space. That different space, if it's mechanically not working right, causes pain. Okay, now I hope that was clearer than mud. But basically, if we let me figure out where my camera is here. Okay, if we start off with this, we put an injection in, this happens, and then that can happen. Then the injection goes away, and we're now in a different space from where we started, right? We started here, we're now there. That's pain. What I have found in my clinical experience with my patients is I'll give them 2 or 3 days and let everything from the injection calm down. If they're still in pain after that 2 or 3 day time period, they come back in. It takes literally 5 minutes to mechanically get the knee working right. And then they go away feeling better and they get to heal with a working knee.
Mm-hmm.
What it sounds like in this case is the injection went in, you got some swelling on top of the injection that really pulled the knee apart. Things shifted. Now they've tried to settle, but the knee isn't working correctly mechanically. That's your discomfort. And because it isn't working correctly mechanically, that's also your swelling that won't go down. Now, unfortunately, it's like see somebody like me kind of answer to the question. You got to find somebody who understands how to diagnose the knee from its mechanical moving parts, figure out what's not working, and then gently get it working.
Mm-hmm. So building upon that, is it more beneficial to get a mechanical working with the knee at the same time of the injection, or is that something you want to separate?
Boy, I don't even know how to answer that because I never separate them. I do the injection, always put my hands on and make sure it's working right before I release my patients. So that's the way it makes sense in my brain.
Sure. And there's a big if there, and it seems to be she's going to a conventional medical doc.
Correct.
Who is only capable,
right.
Only has the capacity to do the Prolozone injection.
Correct.
And not the mechanical working with the knee joint to get the relationships of the bones working together.
Yes, absolutely.
So,
and that's where, in my experience, it's almost like you need, and I'm going to say like an osteopath, someone who practices orthobiotomy, maybe even a good massage therapist, right? Exactly. But people who are trained to look at the knee conventionally
mm-hmm.
don't understand those subtleties that can cause pain.
Mm-hmm.
And so many people that I have seen who have gone to chiropractors, and I'm not bashing chiropractors at all, but the chiropractors don't understand the knee the same way that I do. Mm-hmm. So these patients come in after having seen their chiropractor because there's still things going on in their knee that weren't addressed.
Mm-hmm. Got it.
So in a perfect world, yes, you'd get an injection. Either the same person or a different person would look at your knee, get it mechanically working right, and then you'd be better on the other side of that.
Mm-hmm. Got it. We do have some people on the line here, and we are getting some questions. If this information is valuable to you, give it a thumbs up, like and subscribe to the Comella Foundation channel. Turn on notifications for future videos. Make sure you share this video with your friends, family, and loved ones. Let's see. We got a question here from a Facebook user. I had extensive knee surgery in 2016, ACL graft and lots of other repairs, reefing, etc. The outside of the kneecap posterior patella still has fluid in a pocket that has never been absorbed. It causes limited range of motion. Can anything be done, or am I just like this now?
So I'm going to give you two answers because that's the way my brain thinks about it. So first of all, can anything be done? Absolutely. Mm-hmm. The first thing is, if there's a fluid pocket, technically we would call that a cyst. So it's fluid within some kind of membrane, and I think like a sandwich bag. You can probably, with guidance of either ultrasound or fluoroscope, depending on where it is in relationship to the bone, put a needle into that and draw the fluid out. So that's the first thing that I would consider. Minimally invasive. They give you the local anesthetic, put a needle in, draw the fluid out. It goes away. Mm-hmm. If it goes away and stays away, nothing else needs to be done. If it goes away and comes back, then the simple way of thinking about it is the body needs that fluid there to protect itself. So then you have to figure out how to get that fluid to go away by removing the body's need to protect itself. So you've got to heal what goes on underneath. And that could be a knee treatment. It could be injections with prolotherapy or prolozone, or it could be a combination of getting that cyst removed and prolo or prolozone.
Mm-hmm. What has been your experience from a mechanical standpoint? So a person has this pocket of fluid, and then they start getting the bones in the knee, in the leg lined up. What amount of results could someone get an idea to expect just by getting the bones to line up, be in the right relationship?
So again, it feels like complicated answer because depending on the extent of the injury, the number could be high or could be low. Sure. But let's take something simple.
Okay.
So the patella, the kneecap, is technically supposed to sit more or less in a groove. Okay. So it moves in, and I'm going to emphasize the word relatively, the same area. It slides up and down in a channel. From what we know now about its movement, it actually moves like in a fractal pattern. So technically, it never really moves the same way twice, which is kind of cool. That's why it doesn't typically wear down unless you have a problem. So if we have a mechanical problem where it can't move freely, then it tends to rub more in one place than being able to move free. And the idea there is to figure out what is causing it to be in the same position, freeing that. Hopefully, if the wear in the cartilage and the bone isn't enough, isn't big enough, then it can go back to moving normally again, and over time the body will heal itself. If that damage is big enough, then you may have to do some other things to get it to move normally again, like injection therapy.
Got it. Okay, but this person, Facebook user, had some extensive stuff: ACL,
right?
ACL surgery, lots of other repairs, reefing. I'm not familiar with what
Me either.
Okay, well,
great knee surgery.
Yeah, knee surgery. Okay. Anyhow, when it gets the more injury, accident, trauma, surgery that goes into that equation, it makes it exponentially more challenging for the body to resolve.
Correct. And you can have surgical scarring or adhesions that by the nature of themselves alone can limit, inhibit, or alter normal functioning of a knee.
And then we could also look at the prolozone injections as a way of breaking down or breaking up the scar tissue in addition to the manual manipulation.
Absolutely.
Okay, cool. That was a question. If anybody else has questions for Dr. Beck, please type those in the comments section. We'll be happy to address those this morning. Let's see. We got Sherry's question about the prolozone injections. We had the we have on the back burner the question about the bunion on the same side as the chronic knee pain. So that one's out there. We'll get.
Haven't forgotten about that.
And then we also have a question from Catherine, who asks, let's see, water, inflammation, and rest are all good, but can you provide techniques or applications to support these solutions to knee pain?
Wow, can you read that one again? Because I want to make sure I understood it correctly.
Maybe give a little bit more context. This was a comment under the 3 top secret natural remedies for knee pain. This is on the Comella Foundation website.
Got it. Okay.
Catherine writes, water, inflammation, and rest are all good, but can you provide techniques or applications to support these solutions to knee pain? And there's a little bit, let me give context. We're providing information to get people thinking in a different direction. Big part of it is getting them thinking in a different direction, that it isn't all drug shots, surgery, physical therapy that they need to go and do. So we're opening up possibilities of it, and we're in the process of developing the Comella Foundation website in a way that can help more people. So that could be something we can certainly look into. That one of the suggestions that you had was seeing someone in person, someone very much like yourself, osteopath that specializes in manual manipulation. You mentioned orthobionomy. There may be some other modalities that can potentially be helpful.
Anyone who's skilled at what they do and understands the anatomy really well.
Okay, so there's an option as far as that goes. On the other end of the spectrum is what I've set up. The Knee Pain Guru. I work with clients around the world, so there is that as well. And then we have the Comella Foundation somewhere in between that we're trying to figure out how we can do that, offer classes, probably do that online and things such as that. So we're in the process of that, however.
So the answer was, is there something you can do at home? And that was the question. And so the answer is certainly. It is easiest to teach this one-on-one or in a small group, hands-on, because then you can guide people if they're making small errors. But the principles behind it are easy. So if we take and we limit to the knee, you're going to take a finger, one finger only, poke around front, back sides of the knee, find a spot that is sore. Okay. And typically, if the spot that's sore is here, you want to try to fold the body around the spot until the pain significantly diminishes or goes away. Hold this position for approximately 2 minutes. You can go longer, but not really shorter. And then very, very slowly, you come out of the position and recheck your pain. Now, like I said, it's much easier to show that to people, how to do it on the inside, the back of the knee, all that kind of stuff. But that's the quick answer.
It's based on principles.
It's based on principles. Absolutely.
If the body is in a position of comfort, it lets go of what it's holding on to. It feels safe, supported, listened to. Bingo.
Yep.
It's that simple, that complicated. And that's another reason why Dr. Beck is answering these questions in a way to wrap your head around thinking differently about your pain. If you think differently about your pain, then Charlie, what you just shared about creating comfort around that spot, moving the body where it significantly reduces or eliminates the pain, then you're going to be able to look for that because your brain is in a place of being able to recognize it and see it.
Correct.
Cool. So that was for Catherine. Make sure, Catherine and anyone else, you're on the mailing list. We send out emails a couple times a week, keeping you posted of new events and happenings. You can also check out the pain relief portal. Let me see if I got all of this is also going to be in the description box below. Let's see. I don't have it. So let me get that together. It's going to be in the description box. Oh, let's go to feet then.
Okay, perfect.
While I'm typing.
So I am going to do my best to share my screen here. I've never tried this before on this software, so let's see what happens. Share screen.
Do I need to give some sort of permissions on it?
Allow. Select window or screen. That one. Then we come back to here. Oh, screen. We'll try screen 1. That's not it. We'll try screen 2. That's not it. We'll go back to screen 1. Let's do that one. Okay, allow. Okay, hang on a second here. Share screen. It's saying it can't find one. Allow. Can't do that one. Oh, no. We got one more to try.
Okay. Well, while you were doing that, I got the pain relief portal. So what I was suggesting to Catherine is on the Comella Foundation website, we have a pain relief portal where we have a Jeannie Anderson, she does remote muscle testing, and you'll fill out the information on this link. And she will send you who I have done an interview with on the Pain Education podcast that would be able to help you the most. So check that out if you like.
Nope. It doesn't look like it's going to allow me to share my screen. I'll have to figure that out. Okay, so let's go and answer the question in a different way.
Do you need a picture of a foot? Because I could share the screen and share a picture of the foot.
Oh, if you've got a picture of the foot, absolutely.
Okay.
I mean, but yeah, it'd be nice if I could move my mouse over your picture, but we'll figure that out.
Okay, got it. So skeleton, bones of the foot?
Bones of the foot, yes.
Excellent. Okay.
Boy, I came up with this really nice presentation that it just doesn't like me to share.
Do you want a side view, top view?
Let's go with top view first.
Okay. Let me get to sharing this. Share screen. Oh, that's not. Here we go. Bones of the foot.
There we go.
For some reason, when I click on that, it goes to a
video.
I think. Okay, let me see if I can. There, how's this?
There we go. Okay, great. Okay, so if you're looking at the bones of the foot and you're looking at the metatarsals, so those are labeled on the right-hand side of the drawing. There are 5 of them. The big toe is the one we're going to worry about. And we're going to go to the toe end of that metatarsal bone. So right where your mouse is.
Right here?
Right there. Yep. That is where your bunion will occur. And so if we're looking at the screen, that metatarsal bone goes at its end where the mouse is. It moves to the left. So it moves toward the middle. Exactly. Okay. That is technically what is called a bunion. And then
Charlie, real quick, let me read the question again because we were talking about that a while ago. What does it mean? This is from Kathy. What does it mean in osteopathic medicine if you have a bunion on the same side as your chronic knee pain? So here we are, bunion on the same side.
Okay. So first of all, we define what a bunion is, and it's that joint moving to the middle. Okay. That is technically our bunion. Then we have to look at why it moved. Okay. And so to understand that, we have to look a little bit at how the body works in relationship to pain. And one-celled organism, if I remember correctly from, goodness gracious, this was probably high school chemistry, planaria. So a little one-celled organism that can move on a plate of glass. When you give it a noxious stimulus, it moves away from the noxious stimulus. Okay, so same thing happens in the body. If you injure that joint, the body moves away from that joint. It basically lifts the big toe. Mm-hmm. Now, this is something that you're not going to see on an X-ray, CT, MRI, ultrasound. your podiatrist probably isn't going to know about it. I figured it out because I had an injury on my toe.
Mm-hmm.
That's literally how I got going down this path. But it lifts it, and we'll say it lifts it 0.5 millimeter or 1 millimeter. We're not talking much.
Mm-hmm.
You still walk. You don't feel any different until after it's treated, but it lifts it. And so what happens is when we lift that big toe off the ground, we shift the mechanics of how the knee works. Okay, we go from a knee that is balanced. And so in the picture, we're looking at the right leg.
Mm-hmm.
So it's balanced to when that bunion comes in and we lift that big toe, we're shifting the weight from evenly distributed to the outside of the knee.
Mm.
Okay. Because we're taking the weight off the big toe and putting more weight on the outside of the foot.
Got it. So
Now,
this could be like wearing flip-flops is one of the things that pops into my head. How we got to grab with the toe. We have the flip-flop.
yes.
That little sandal thing.
Yep. And you're going to grab less if there's an injury.
Mm.
So absolutely, that is what happens. And day 1, this isn't a big deal. Day 10, it isn't a big deal. 10 years in, it's a big deal.
Right.
Because then Wolff's Law has changed the way the knee functions.
And let's we want to recap Wolff's Law real quick.
So Wolff's Law is the tissues of the body grow based upon the forces placed upon them. And the easiest way for me to think about that is if we ask anyone to go and lift weights, day 1, they might be able to do the bar if they're not doing it consistently. But, by 1 or 2 years in, they're lifting a whole lot more and their bones are actually stronger because their body has said, ooh, I'm using these in a different way. I should put down more bone to be able to handle the forces.
Which is why they suggest for people to do weight-bearing activities as they get older to combat osteoporosis.
Absolutely.
Okay. So, was there anything else you wanted to go in for Kathy on that?
Nope, that's it.
But that's okay. Cool. Let me stop the screen share here. Excellent. How are we doing? Oh, well, we're at about 30 minutes in.
Yep.
Okay. Well, those were the questions for today. We covered the foot. We covered bunions. We covered prolozone injections in the knee. And what else did we cover? Techniques or applications to support the solutions to knee pain. Cool.
Awesome.
Excellent.
And now that I know that my share won't work, I'll absolutely have to bring home my models so we can look at those.
Cool. So if anybody watching the replay has questions, would like to ask Dr. Beck, you can go ask Dr. Beck a question about their situation. Once again, Dr. Beck's going to give a completely different perspective than the conventional medical model of drugs, shots, surgery, physical therapy. It's going to be more of from a classically trained osteopathic perspective that specializes in manual manipulation. And you have extensive background in other interest modalities and things like that you bring to the table that is a very, very unique perspective. So you can ask those questions on the Comella Foundation.org/ask Dr. Beck. All of these links are in the comments section, not the comments section, the description box below. You can go onto the Ask Dr. Beck page and do that. We normally go live on Wednesdays at 7:30 a.m. Eastern time. Let's see. Anything else, Charlie, we should cover?
I think that's it.
We got the Pain Relief Portal, and we also have the Pain Education Podcast on the ComellaFoundation.org website. Charlie, Thank you so much for being here. Appreciate you very much.
Thank you, Bill.
Have a wonderful day, and I will see you next week.
Sounds good.